Good morning, dear professors and colleagues. I'm Lamia Mamdouh, and today I'll be presenting a case courtesy of Dr. Mohammed Fakhri. Our patient is a 10-year-old male patient who came complaining of blurring of vision in his right eye. Upon examination, the only significant thing was the refraction of the right eye. The patient's vision was 0.3 that corrected to 0.6 with -4 astigmatism, and the left eye examination was completely normal. So accordingly, bilateral pentacam was done, which showed keratoconus grade 2 in the right eye according to the corneal thickness and the back elevation, while the left eye pentacam was completely normal. Decision to do corneal cross-linking was done using accelerated protocol EPI-off. Upon the 1-month follow-up, the patient was completely the same. The vision was the same due to some mild corneal haze. However, on the 1-year follow-up, the patient showed marked improvement in his uncorrected and corrected vision. Serial pentacams were done over the next 2 years that showed stability in his Kmax upon 50, 50, 51, and his astigmatism improved a bit. Also, over the ABCD progression display, the patient showed stability. All throughout the 2 years follow-up, the patient showed no changes in his left eye. As you can see, the pentacam was completely normal. So, is this a case of unilateral keratoconus? Some reports say that yes, even though it's rare, unilateral keratoconus may occur with an incidence ranging between 1 to 4%. However, most studies show that many forms of form frost keratoconus, fellows' eyes progress to true keratoconus over the long term. And many believe that there is a global consensus that keratoconus is linked to genetic factors and systemic associations, and therefore true unilateral keratoconus does not exist. So what's the explanation behind unilateral cases with no signs of keratoconus, whether clinically or in investigations in the fellow eye? Ambrosio et al. Introduced the term corneal ectasia and attributed this changes to a mechanically induced ectasia due to some causes as rubbing the eye. As in this case report, the patient had unilateral corneal ectasia, and by proper history taking, it showed that the patient was used to rubbing only his right eye, and they stated that no changes will occur in the fellow eye without another destabilizing event as the patient rubbing this eye or something else external. Eye rubbing has been linked to corneal ectasia in several studies, and it's not undergoing many changes and many studies to show if it's truly reversible and is it the only factor to induce this change. By taking history from our patient, it turned out that he did, in fact, was right-handed and that he did rub his right eye. So we think that this might have been a case of corneal ectasia and not keratoconus, and that if we did not intervene, then he would not have progressed either. So my take-home message is pediatric clinical keratoconus is for cross-linking and follow-up. Unilateral keratoconus is rare, so assume bilateral and keep follow-up. If it's true unilateral, consider mechanically induced ectasia, and you can confirm this by longitudinal data collection and epithelial mapping. If the decision or diagnosis initially is made that this is a case of ectasia, then we may just follow up the patient. Thank you.